Good evening. I am Dr. Anil Parekh, President, Medical Affairs and Clinical Research at IPCA. It gives me great pleasure to welcome all the uh, medical fraternity who have joined across the country for this important update on hypertension guidelines. There has been a recent update from the ACC-AHA 2025 guidelines have been released. So we would like to see what is the implications of these guidelines on Indian hypertension patients. And to chair this important CME, we have Professor Soumitra Ray, who is a very renowned and academically inclined cardiologist. He is ex-professor Vivekanand Institute of Medical Sciences and vice president Cardiological Society of India, and he stood first in order of merit in higher secondary MBBS and MD examination. So prolific academic record. Pursued MRCP in UK after MD from Calcutta Medical College. He is trained in intervention cardiology at Royal London Hospital, London, and published many articles. And he is always there whenever we ask for his help in CME. He is always there for us. And uh, editorial board of Indian Heart Journal, represented CSI, and always a prolific lecture. Always he's there in all the CSI conferences. He's acclaimed literary clinic and debate and orator. So now we have Professor Venkatram, who is known to all of us. Uh, he's numero uno in hypertension in India, and is Director, Academic and Scientific Affairs, Indian Society of Hypertension, Professor Clinical Medicine, University of Texas, Southwestern Medical Center, Director, Texas Blood Pressure Institute, Dallas, Texas, Dean Maguire University, Medical University, Sydney, Australia, and based one of the topmost hypertension experts and listed in Who is Who, author of more than 410 publications, 9 books on hypertension, recipient of Lifetime Achievement Award and Musa Award from American Society of Hypertension, received Padma Shri from the Indian government for his work on hypertension, and Dr. Harshvardhan described him as the global hypertension icon. And then he will be moderating the session as well as also will speak. Will get his take on this ACCH 2025 guidelines as well. Then we have Professor Paul K. Welton. Professor Paul K. Welton is widely known across the globe as the 2017 main lead author of the guideline 2017 ACCHA guideline, the previous guideline before the 2025. And also he is known through his work on World Hypertension League, and I also know him through that work. And he is a faculty member at Tulane University's Celia Scott Whitehead School of Public Health and Tropical University School of Medicine, New Orleans, Louisiana. Immediate past president of World Hypertension League and global public health acknowledged leader in cardiovascular disease prevention worldwide. Then the next lecture would be by Professor Franz Messerli, and I've been very fortunate to be associated with Professor Franz Messerli, and he's guided us over the years, and we have now almost more than uh, you know 12, 15 years of association with him, and we are very fortunate to receive his take. He's an expert, acknowledged expert in hypertension, cardiovascular disease, and specializes in preventive cardiology. Guest professor, Swiss Cardiovascular Center, University Hospital, Bern, Switzerland. Emeritus professor of medicine, Mount Sinai Health Medical Center, Icahn School of Medicine. Visiting professor uh, in University Kharkov, Poland. So before handing the session to Professor Soumitra Ray, I would like to say that we have 3 hypertension greats who will give their take on hypertension guideline. And the major thing which I find in these guidelines compared to the previous guideline is that there is a much more emphasis on tighter hypertension control, although that started with the previous guideline with where Professor Paul Welton was the lead author. But the emphasis is still more enhanced in these guidelines. And other is the emphasis on CV risk, which should, like lipid guidelines were the first to adopt the CV risk approach and the lipid lowering based on CV risk. But here also now CV risk, the prevent CV risk score has been emphasized in these guidelines for hypertension control. And other is the clothianidone and hydrochlorothiazide and indapamide has been listed as thiazide type diuretic. And Professor Messerli had a very interesting take on the 2003 JNC 7 hypertension guideline when they mentioned thiazide type guidelines as and they were discussing chlorthalidone in those guidelines. So that's another thing. And other take is that till 12.5 milligram chlorthalidone is just recently approved in US. So before that, both in US and Europe, there was no chlorthalidone 12.5 milligram, and Europe still don't have. So they had 25 and 50 milligrams. So this was what was the status of and but we had done a pioneering work on both 12.5 as well as 6.25 milligram chlorthalidone and combinations. So with these, beta blockers are still not featuring, although they received some importance in the recent European guidelines, but they still have the effect of Dr. Franz Messerli that they are still not primarily in the primary treatment of hypertension, but more with comorbidities, heart failure, and coronary artery disease. So with these introductory remarks, I would like to hand over to Professor Soumitra Ray to start the proceedings. Professor Soumitra Ray, please.
Thank you, Dr. Parikh. That was a very, very neat and very crispy introduction to the faculty as well as to the subject. And I am honored to chair a session where the four doyens of hypertension who shape the past, present, and future of hypertension, who write the guidelines, who teach us how to look after hypertension, they are with us as speakers. And all the delegates, welcome to this evening. And you agree with me that hypertension never stops surprising us. A very simple example. Earlier this month, there was American Heart Association hypertension seminar at Baltimore. And many things were discussed. I found it absolutely intriguing. There was a sprint trial subset analysis where they showed that the people who have postural hypotension and postural hypertension have got high baseline NT-proBNP and high baseline troponin T. Fair enough. Then they showed that after 1 year, these people, those who have postural hypotension, they have increased NT-proBNP and increased troponin in a significant way, indicating subclinical cardiac damage going on. And surprise, surprise, that those people in the intensive treatment arm, when your systolic pressure was below 120 rather than below 140, they had lesser increase of this NT-proBNP and troponin T, indicating thereby that their chance of subclinical cardiac damage is less. This is counterintuitive because almost all of us, when see a patient of postural hypotension, tend to reduce the antihypertensive medicine. We get feared, we get scared. So this is a surprise. So many surprises are still awaiting us in the field of hypertension. And I'm sure for the next 1.5 hours or so, we will get surprise after surprise from the doyens of hypertension from all over the world, from America, Professor Welton, from Switzerland. There's Professor Messerli, then whom we look after as the last word of hypertension in the Indian subcontinent, Dr. C. Venkatram, and our own Dr. G.S. Wonder. They will surprise us. So I will see that we will have a very pleasant and enjoyable, fun ride for next 90 minutes. So tighten your belt, hold the rods tight, and enjoy the ride. Professor Welton, please.
Wonderful. Thank you so much, Dr. Soumitra. It's a wonderful pleasure to be with everyone today. Let me just bring up this slides here. I am going to talk mostly about the newer lower targets in our recent blood pressure guideline, but I will touch a little bit on some other aspects of the guideline as well. And I have no particular conflicts of interest. I can skip this slide for time. So I would say in start that the 2025 American Heart Association, American College of Cardiology blood pressure guideline is in essence very similar to what we published in 2017, but there have been some changes. And at the very start of the guideline, you'll see a table 1, that has the major modifications that we recommended. And I just picked out the ones that I think are the more important. So one of the things that we put a good deal of emphasis on was primary aldosteronism, because I think we all recognize now that it's far more common than we thought in the past, and it often is there even when we don't see the very typical pattern of low potassiums and so on. So when there is high pressure, especially if it's resistant, that's a good time to be thinking about it and screening for it. I won't go into the details today. We have a good deal of emphasis on pregnancy and hypertension too. And I think the two big things I would take out of that is we've expanded the list of drugs that we would recommend avoiding in women who plan to become pregnant or may become pregnant, and take a look at that. And the other thing that I think is important for any of us in, who are internists or in primary care is there's a recommendation for use of low dose aspirin, 80 milligrams, so the baby aspirin. And that's for any woman who has had chronic hypertension before becoming pregnant or develops new onset hypertension before week 20. And that's because there are now trials that demonstrate quite clearly that low dose aspirin in this setting reduces the risk of preeclampsia. So I think that's an important thing for all of us to be aware of if we're in primary care practice. We've slightly expanded the list of non-pharmacological approaches, and I'll touch on that in a moment. We've introduced a new risk indicator called PREVENT, and I'll touch on that too. Slightly expanded settings for the addition of blood pressure lowering medications, pharmacological treatments, especially in individuals who are at low cardiovascular risk, and I'll mention that. Some new recommendations for management of hypertension in those with comorbidities, especially, of course, in those who have diabetes and those who are overweight, worry of access to SGLT2 inhibitors and particularly GLP-1 agonists. I'm going to focus on the targets in a moment. We did provide advice on the use of renal nerve denervation, and I would just say it's very cautious. That really before this is used, one has to be sure that patients have had a very good treatment to make sure that their resistant hypertension cannot be managed in more conservative manners. And we've also recommended two other things. One, that there is a good discourse with the patient, that it's an informed decision on the part of the patient as well as the therapist, and that it really should be done in centers that have a lot of experience with doing renal nerve denervation. And then we have changes in terminology. The most important one, I think, is where we used hypertensive urgency before, we're recommending using the term severe hypertension. And that's because no matter what was written for the management of hypertensive urgency, which would be somebody who has a very high level of blood pressure, let's say a systolic over 180, but they don't have any obvious target organ damage that is current. In the past, because of the term, many of these individuals were treated rather aggressively, many times with intravenous therapy, and that's not indicated. So we felt severe hypertension might be a better term, and in those patients, they should be treated as outpatients. So with that as background, let me just say quickly, this is the overall approach to the management of high blood pressure. It's similar in our guideline to other guidelines at the lower levels of blood pressure, focusing on non-pharmacological therapies, and at the very high levels of blood pressure, adding in antihypertensive drug therapy, and somewhere in between what we would call stage 1, that's 130 to 139 systolic, 80 to 89 diastolic, trying to understand, does the individual have a high underlying cardiovascular risk, either because they've had an event already, so they're obviously at high risk, or they've got some phenotypes. They have diabetes in addition to blood pressure, they've got chronic kidney disease, or it's not in the guideline, but I would add in they're at older age. All those individuals have high risk. We have used a new calculator. We used the pool chord equations in the past, but we've replaced that now with what's called the prevent calculator. And the reason for that is this is a calculator based on much more current data, a much larger database, over 6 million participants. It importantly includes heart failure as one of the outcomes, and it has many other benefits. It really can apply and has been validated in a much wider range. It, of course, was developed for the US, but I would say compared to the pool chord equations, it's probably going to be a more transportable risk predictor. And the problem with all of these risk predictors is that they're not very transportable. They're developed for a particular population. They work well there. So we're suggesting using the prevent and the percent cut lines for what's considered high risk is different. It's 7.5% for prevent. Prevent does a better job in actually identifying those who are at high risk on the pool chord equation. So that's an important change for us. I don't know the percent who would be high risk with the prevent approach, but with the pool chord equations, about 30% of those who had stage 1 hypertension were considered to be high risk. And in that setting, we clearly recommend adding medication to non-pharm. For those who are not at high risk, we recommend treating them with non-pharm for at least 3 to 6 months, giving a good set of treatments. And if that doesn't control blood pressure, considering adding in antihypertensive drug therapy. And that's really on the basis of experience in the PREVER trial, where this type of approach regressed left ventricular mass and left ventricular hypertrophy. So non-pharms, they're basically the same core 6 that we've recommended in the past. I mentioned SGLT2 inhibitors and GLP-1. SGLT2 inhibitors are not FDA approved for blood pressure. They're not antihypertensive agents. They're not classified, but they will give 4 or 5 millimeters of mercury reduction usually. GLP-1s, of course, give you much bigger reduction in blood pressure. It's largely, but not completely, weight related. So you can get big weight losses and big reductions in blood pressure. Obviously have more side effects, particularly gastrointestinal side effects, and sometimes serious side effects like pancreatitis. The healthy diet is about the same. For sodium, I will say one of the things we recommended in this guideline was salt substitutes. And of course, we have the salt substitute trial from some years ago, but there are several other trials now. And there was a recent WHO meta-analysis of close to 30 trials in which sodium, we're using these substitutes, about 25% replacement of potassium of sodium with potassium. They gave about a 10% reduction in sodium, enhancement in potassium intake, about a 5 to 7 millimeter reduction in systolic blood pressure, and significant reductions in all types of cardiovascular disease outcomes and all-cause mortality. So it's a very simple it can be a little more costly as a salt, but for people who can't or follow non-pharmacological interventions well, this is an easy substitution. Physical activity, the only thing I'll mention there is increasing publication that isometric resistance, in which you don't move the joints, it's poses like yoga or wall planks. I must say it surprises me, but that's what it is. Now the core really for blood pressure reduction is still typical aerobic exercise, brisk walking, dancing, swimming, etc., usually coupled with a little bit of dynamic resistance like push-ups and those sorts of things. And then for alcohol, I work with colleagues in Italy and Modena, and we've published recently some very large cohort studies with both blood pressure and hypertension as the outcome. And they've shown very clearly that from the lowest intake of alcohol, you start to see increases in blood pressure. So we're now recommending, just like the WHO has done for many years, abstinence if that's possible. For many people, that's not possible. And there, of course, we recommend modest intakes of alcohol. And the last thing is we added this year a specific recommendation for stress reduction. I will say the data are not very good, so it's at a much lower a much lower COR or strength of recommendation, and the quality of the evidence that surrounds it is much poorer than the other six. The drug therapy approach remains unchanged. If it's a compelling indication for a drug that lowers blood pressure because of a comorbidity, of course, that should come first. If there's no compelling indication, the four usual classes, diuretics, we prefer the long-acting like chlorthalidone, indapamide, calcium channel blockers, particularly the dihydropyridines, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers. And most people require at least two, because one drug will get you on average about 9/6, which is usually not enough. Most people have need for a greater reduction in blood pressure. We now, like you, have lots of dual combinations in the US, over 30. As single pill formulations, they are very price competitive. There's really no reason to be giving these drugs separately anymore. And the notion with these single pill combinations, of course, is that you're using lower doses. Most of the blood pressure effect is seen at lower doses, quarter dose or half dose. And the side effects, while uncommon, are dose related. So combining lower doses of drugs gives you much better blood pressure reduction and much less in the way of side effect. And then if two don't work, go to three. We in the US only three approved triple therapies. They're still a little bit expensive, although there are generics, but I think we'll see a lot more. I imagine in India, you've been at the center of single pill combinations. You probably have more. And of course, if still uncontrolled, then they need really a workup for resistance hypertension, or refer to somebody who is a specialist and knows how to do that. And if it's true resistant hypertension, which is only in a minority, adding in receptor antagonists like spironolactone. So that's our approach. Now, in the 2017 guideline, we recommended a blood pressure target of less than 130/80. And there was unanimous agreement at the time, and we did a particular meta-analysis ourselves and documented that benefit, as had been seen in many other meta-analysis. I will say we had discussions. In fact, there were several meta-analyses before we published the 17 guideline that suggested even lower pressures might be better. And I show one here on the right-hand side. It's the most powerful of these. It was done by our group. It's a network meta-analysis. And you'll see even down to a comparison of 120, 124 versus 125, 129, there's benefit for all of the outcomes. So you might say, well, why didn't you recommend a lower target in the 2017 guideline? And I would say, well, We didn't say you couldn't go lower, but we had unanimous agreement on less than 130 over 80. And when we looked at the meta-analysis that suggested lower pressures at the time, they came from a pooling where the blood pressure differences came from three types of trials: comparisons of drug versus placebo, more versus less intensive, and randomization to different blood pressure targets. We felt, of course, that the latter group, the randomization to different blood pressure targets, was really the best design to answer the question. It's what you call the gold standard trial for this question. And there was only one such trial, that was Sprint at the time. So that's why we didn't go lower. By now, we have quite a few additional trials that have provided information in randomizing to less than 130 or less than 120 compared with higher blood pressure targets. There are actually 8 of them, and I'm showing them here. You see 5 on the left that compare less than 120 with higher, or the higher in every instance is less than 140. They're all pretty much modeled on the Sprint trial. And there are 3 on the right-hand side that are less than 130 compared to higher pressures. The nice thing when you look at this is you're really testing the question of a very heterogeneous group. So it's people from the US, from Japan, and from China. It's people with a variety of ages, particularly older adults. We don't have good information in younger adults for event. A lot of information, a bit of a range of age. We've got a mix of demographics. We've got trials that have included 100% diabetics, that have included 100% stroke, trials like Sprint that have included a lot of patients with chronic kidney disease. And we've got trials, many of them, that have included quite a few older people over the age of 75. And we've got 3 types of trial design. The typical 2-arm parallel design was the most common, but we also had factorial designs, and we had cluster design trials. So when you have that, if you see a consistent message coming from all of these different settings, then you're pretty convinced. And what I'm showing you here is what we call a forest plot. It's comparing in the upper part of the slide, the upper panel, less than 130 target versus higher, and in the lower, less than 120 versus higher. I will tell you, in all of these trials, blood pressure was measured at very high quality, as was all of the cardiovascular outcomes. And I'm using here the most conservative approach for pooling, random effects model. It assumes nothing, no rules. You could use a fixed effect model here. It probably meets that and would give you even stronger results. But you don't have to apply any statistical model here. You can just look at it. There's a line of identity, and you'll see every single trial is to the left of the line of identity. So every trial, no matter how it was done, is telling you lower is better. They may not all be statistically significant. Many of them are, but they're all showing the same pattern. And whether it's the less than 130 or less than 120, it's well to the left. And when you pool them, it becomes very convincing. For both of these comparisons, you'll see about a 20% reduction in major cardiovascular events, for the lower being better than the higher blood pressure target. And when you look at the individual outcomes, whether it's stroke, coronary heart disease, heart failure, or cardiovascular mortality, there's consistent evidence of benefit for both of these comparisons. Now, none of these trials were powered to look at all-cause mortality, which obviously is clinically a very important outcome. It's also statistically important because you essentially can't get it wrong. You may not know what somebody has died for, but you're in these trials usually 100% certain of whether somebody is alive or dead. So looking at all-cause mortality is not as striking as for cardiovascular events, but it's still pretty impressive. Most of these trials are to the left, and when you pool them, it's statistically significant, about 10% benefit. As I mentioned, I use random effects model here. You could probably realistically and reasonably apply a fixed effect model, which doesn't assume variation between the trials. And then you would get a tighter confidence interval, but it wouldn't change the overall estimates. So very impressive. Now, we also tried to look at adverse events. And I would have to say in these trials, those were not measured with the same level of quality as blood pressure or cardiovascular outcomes. And you've got a strong potential for overestimation because unlike the beneficial outcomes, which we very carefully only measure at specific trial visits, so it's like versus like, for adverse events, for ethical reasons, we'll take them whenever we have a contact with a participant. And in these trials, the more intensive group, you have more contacts with them because you're titrating their blood pressures. Even after you get them controlled, you're titrating. In sprint, it was about 30% more contact. So you have more opportunity to have reports of adverse events. So there's a little bias here, but even with that, there are adverse events reported, as you would expect, but they're not very common, and they don't seem to be hugely I won't say they're not important. They are important, of course, but they're not anything like as important as a beneficial outcome. So the most common one would be hypertension, which of course is just a blood pressure measurement. Syncope would be more important than hypertension. It's even less common. You'd have to treat about 2,000 people to get one report of syncope for the less than 130 versus higher, and about 1,500 for the less than 120 versus higher. So it's reported, but it's not reported very commonly. Now, the more important outcome of all of these would be if you got syncope and you fell and you had an injury like a hip fracture or something like that. And it does happen, but you can see it's not very common. You'd have to treat about 3,000 people before you would see one such event in these trials. Electrolyte abnormalities much less common in the trials these days than it used to be in the past because we're using lower doses of these agents. So again, occurred, but not very common. And there were reports of acute kidney injury, acute renal failure, but they're really quite uncommon. And most of those are really a lowering of GFR. And what you see in these trials and what we saw in spring was an intensively treated group. We saw an immediate lowering of estimated GFR. And after titration from 6 months on, the pattern for renal function change was identical in the intensively treated group and the standard treatment group. And most of these, when we investigated them, were pretty mild. They were one-time occurrences. They just went away. And they seemed to be hemodynamic. And the reports of acute kidney injury, acute renal failure seem to be more reports, perhaps for insurance purposes, and they are serious. Not to say things couldn't occur. None of these trials have ever reported anyone getting end-stage kidney disease, for instance, or doubling of serum creatinine or traditional outcomes. In fact, in sprint, we did see the reduction in eGFR, but we saw a beneficial effect on albuminuria reduction in the more intensively treated group. So based on all of that, our recommendation in the guideline was for high-risk individuals, high confidence in the data, and a strong recommendation for less than 130, with encouragement, if possible, to go to less than 120. We in the people who were not at high risk made the same recommendation, but it was not as strong and it was with a lower level of confidence in the data. And we didn't change the recommendation for diastolic from what we'd had in 2017, less than 80 for both groups. We did make one additional new recommendation, and that was all for all the comorbidities. We said less than 130 over 80 with encouragement to go to less than 120 if feasible. For cognitive impairment and dementia, we're seeing a lot of new information. And I will say in all of these trials, no trial has ever reported a worsening of cognitive function or a worsening of dementia. So that's a good starting point. Many of the trials have either not done good measurements or have used very crude indicators like mini-mental MMSE, if you're familiar with that. And that's a type of instrument that will pick up gross cognitive impairment, but it won't pick up subtle cognitive impairment. So it's not a very good instrument. Sprint put a lot of emphasis on looking for cognitive impairment, and we had a very sensitive set of indicators. We saw a reduction in cognitive impairment within 6 months, better in the intensively treated group, and it was there throughout the trial. The trial was stopped early, so we didn't have enough dementia events, although the pattern was for a favorable outcome. In the community healthcare worker trial in China, it went a longer period of time, had a bigger reduction in blood pressure, so they had more power to answer the question. They used the mini-mental, which, as I mentioned, not a very sensitive indicator, but they still saw a beneficial effect in cognitive impairment, and they saw a 15% highly statistically significant reduction in dementia. Both of these trials, when you combine the two, cognitive impairment, dementia, reported significant benefits. So we, on the basis of these trials, recommended less than 130 over 80 as a way to try to prevent cognitive impairment and prevent dementia. There are going to be additional trials. We'll see results soon from BP Road, which used approaches similar to Sprint, quite sensitive on cognitive impairment. So that'll be good. And there are two big trials being done in Brazil, the optimal trial in dementia, in diabetes, and the optimal trial in stroke survivors. So as I mentioned, we say less than 130, try to get to less than 120 if feasible. Where does that put us? Well, I'm showing here the recommendations from many guidelines, from the most conservative at the top to the most intensive treatment at the bottom. You'll see there's a bit of a spread, but most of the trials are saying if you can at least get to less than 130, or guidelines I should say are saying get to less than 130. So reasonably consistent, and some of the trials saying get to low pressure if possible. Well, of course, we're far away from that in the US. China, I'm showing here, India is also far away from it, even at the 140 systolic. This is 140 over 90. So we're not doing anywhere as well as we should be doing. I think we all recognize that. If one looks globally, we've done global estimates in 2000, 2010, and we've actually done 2020. That's under review right now. But I will tell you what we've seen each time is slight improvements. But in the most populous countries, the control rates are hovering. Here's 210, and you'll see us hovering around 8% control at less than 140 over 90. Shocking. The most cost-effective approach to preventing vascular disease, one of the best interventions for our patients, and it's not happening. So what do we need to do? Well, I'll say in the US, we know where the average blood pressure is for treated hypertensive. It's about 138, 139. We know that when you're looking at averages, that's 50% control. And if you want to get to a higher level of control, like 70 or 80%, you would need to have the average be lower. So for less than 140, the average to control about 70 or 80%, we need to be less than 130. For 130, it needs to be less than 120, etc. So obviously, we have to get that average down quite a bit, at least 20 millimeters of mercury. And that is a big ask. It can be done. I think the two things that are most valuable here are application of implementation science, and we know things like team strategies and using home blood pressure measurements and other approaches that have come out of implementation science are really effective. And you in a clinical setting or in a trial setting, you can get 10 to 20 millimeters of mercury. Single pill combinations do much better than our traditional approach of using individual drugs, and will generally get at least 5 to 10 millimeters additional blood pressure reduction. There are new classes of agents coming down. I don't know whether they'll contribute much, if anything. There are new injectables coming down, which may be useful for people with true resistant hypertension. Obviously, device therapies like renal nerve denervation have a place. We talked about comorbidity treatments previously, and I think technology is certainly playing a role right now, but there's increasing evidence that AI in the form of machine learning or other approaches may be quite helpful in the long term. So I think it can be done, but it requires a good deal of focus. Working in the World Hypertension League with the World Health Organization, and we put together this HEARTS approach, which incorporates many of these elements. And I'm really excited about that because it is really the big global intervention that's going on right now. 28 countries in the Americas. Of course, you have a big effort in India, as many other countries do as well. So I'm cautiously optimistic, but I know we have a long way to go. So in summary, the 2025 guideline from the US is pretty similar to our 2017 guideline, which is good, but there are some changes. Amongst the most important is a slight revision of our targets to continue to encourage a systolic less than 130, but add to that encouragement to get to less than 120. We've got a ways to go to get to where we want to be, but I think it can be done. Of course, the challenge with guidelines is they're wonderful. They have been very strong in being evidence-based and extremely weak in being implemented. They just haven't been implemented. So we need to have a much stronger focus on implementation. I want to thank you very, very much for inviting me to be with you today.
Thank you, Professor Welton. That was such an insightful talk. And I must say, you have fetched for us the most precious pearls from the turbulent sea of hypertension guidelines. Thank you, sir. But the best stroke of you gave it towards the end, that the target and the reality, there is a huge gap. So first thing is to screen the patient, make them convinced that you need treatment, which will do you benefit, and then to talk about the targets. So those few people who are wise enough, and those few doctors who are wise enough, have got these target issues. But mostly for the majority is detection, and at least something is better than nothing. That is the motto for the time being. But of course, science will progress. Thank you, sir. Hats off to you. We'll expect more questions and answers. Uh, Next, Professor Ram, will you call Dr. Wonder, or
Yeah.
shall I invite him?
Okay, thank you, Soumitra. What happened in the last day or two, Dr. Wander is slightly indisposed, and he was not able to attend to work in the last 2-3 days.
Okay.
He was going to give some idea about the new Indian guidelines that he is developing with Association Physicians from India. I got a verbal permission from the committee to say a few things about the Indian guidelines. I cannot show slides, because it's not published yet and it's not fair also. So the Indian guidelines are almost ready and they will be published in print by the end of this calendar year. And I don't want to upstage what they're going to do. One thing that I had a privilege of reviewing the draft. It's a large document and it is undergoing through committee members a lot of changes and also some external review. One thing that they are doing, Dr. Welton showed a number of countries and regions with different guidelines, some 140, some 130, 135. Indian guidelines that are being not published yet, but looks like they are going to retain the same classification of hypertension as before. Blood pressure mild, moderate, severe, 140, 160, 180. So that is not going to be changed. However, they are going to comment on optimal or ideal blood pressure, which is less than 130 by 85. Not 130 by 80, 130 by 85. So one thing they are doing, which I find it very important, is they have categorized hypertension in a separate category of isolated systolic hypertension with guidelines for isolated systolic hypertension. And interestingly, I think this is the first time I am seeing a category of isolated diastolic hypertension. They have a category of isolated diastolic hypertension, which is increasing, particularly in the younger age group. So, Soumitra, the only thing that I could say is that the guidelines are being developed, the document is ready, and it will be published by the end of this year. The categories of hypertension, they have not changed, although they do comment on so-called optimal blood pressure if it can be done. And it will be interesting to see isolated diastolic hypertension, which is being recognized increasingly. So those are just few comments I wanted to make on behalf of Dr. Wander, and we wish him speedy recovery by next week. So Soumitra, please continue with the next speaker.
Great, sir. So we'll wait eagerly for our own Indian guidelines to come out, as you mentioned, towards the end. Now we swim across the Atlantic and land in the European. And from the beautiful city of Interlaken, one of the best cities in the world, Professor Franz Messerli is with us. Professor Messerli, you have heard and we have done the ACC guideline. Now the ESC and ESH, there are different guidelines. One change, if you highlight in your lecture, in ESC till this year, it was RAS blockade plus either CCB or diuretic. But ACC was always saying RAS blockade, diuretic, and CCB interchangeably. Any two can be combined at the beginning. Only this year, the Europeans have accepted that, yes, any two can be combined. That practically means that a CCB and diuretic combination can be as a starting point. So perhaps we'll just mention about why the change is there. And sir, the forum is yours, Professor.
Thank you so much. Let me get to the slides here. All right. I'd like to just make a few simple comments. And the first one, obviously the most important one, is the target systolic blood pressure of below 120 that you see here in adults with controlled hypertension who are at increased risk. Systolic blood pressure goal less than 130 with encouragement to achieve less than 120 is recommended. I have no problem after what Paul Welton has said that this is indeed correct. I'm just wondering if this is indeed a 1A recommendation. A 1A recommendation. When lowering SBP to below 120 in older and frail patients, and they all fit this increased risk definition, okay? I mean, above age 80, everybody fits the risk definition. And they're also the ones that are most likely to become symptomatic with too low a blood pressure. So the question is if indeed SBP below 130 to below 120 is truly a 1A recommendation, why did we stop at 130? Why did we not just say the target is 120? End of story. So it seems to be a bit of a waffling here, and yet it's supposed to be a 1A recommendation. Okay. Point number 2, beta blockers. The guidelines clearly state BBs were less effective than first-line antihypertensive classes in preventing strokes and had a less favorable side effect. They should be reserved for compelling indications. Yet, when you look at BBs, you can see they lower blood pressure quite well. Here we have a Cochrane meta-analysis, 10/8 millimeters of mercury, rather substantial. So we can say premise number 1, beta blockers are efficacious antihypertensive drugs. And when you look specifically at atenolol, again, the Cochrane, you can see here atenolol lowers blood pressure 15/13 millimeters of mercury in a Cochrane meta-analysis. And we can say premise number 2, atenolol is an exceptionally efficacious antihypertensive drug. Now, quite a few years ago, we did also a meta-analysis looking at outcome. Until proven otherwise, beta blockers no longer should be considered appropriate as first-line therapy in uncomplicated hypertension. We were not the only one. Lars Lindholm in The Lancet here making the same statement. Here you see again the Cochrane meta-analysis, again showing no effect on total mortality, and another meta-analysis clearly showing that beta blockers are not as efficacious in reducing stroke when compared to other antihypertensive drugs. So premise number 3, beta blockers are useless for the treatment of hypertension, right? And that brings us to premise number 4. Look at atenolol. Atenolol specifically looked at The Lancet by Bo Karlberg. Again, absolutely no effect on all-cause mortality, cardiovascular mortality, MI, minimal effect, but not significantly statistically at stroke. And when you look here at stroke in isolated systolic hypertension in life, you can see here a 40% less stroke prevention with beta blockers. And in the total life study, 25% less stroke. In ASCOT, 23% less stroke prevention. So clearly, atenolol is exceptionally useless for the treatment of hypertension. Now, how do you reconcile premise 1, 2 with 3 and 4? Well, it's actually very simple. Blood pressure is a surrogate endpoint. It doesn't mean that when you lower blood pressure, you will automatically have benefits, although most of us started to think so. It's a lifelong habit. Lowering blood pressure is very important, but for beta blockers, this is not necessarily true. So clearly, too, when efficacy is defined by millimeters of mercury, premise 1 and 2 are correct. But when efficacy is defined as MI, stroke, or death, then premise 3 and 4 are actually correct. Now we have to consider that for more than 10 years, US guidelines have recommended beta blockers for first-line therapy of hypertension in the absence of compelling indication. They stopped to do that more than 10 years ago. Yet look at this, and this brings me to what Dr. Welton just has said. This is a study that just came out, published right now. 600,000 patients of the VA who initiated a beta blocker, and that is 88%, had no compelling indication. Beta blocker was just given, just like that, because it's an antihypertensive, it lowers blood pressure. These patients are at the higher risk of stroke. And, the European guidelines have switched beta blockers to first-line therapy without any evidence. And we stated in the Lancet, this not only ignores a careful thought process of many authors in previous guidelines, but also because of inferior stroke protection might lead to widespread harm. And this is certainly true, excuse me, for our veterans in the US as well. Okay, thiazides. And statement here, in a careful designed head-to-head comparison of initial antihypertensive drug therapies, namely NOLHAD, clothalidone was more effective than amlodipine or lisinopril for heart failure prevention and surpassed lisinopril for prevention of stroke or cardiovascular protection among patients with previous MI or stroke. I want you to read that again to make sure this was actually clothalidone. And then the guidelines also state replacing thiazide-type diuretics, hydrochlorothiazide and benzoflumetazide, with thiazide-like diuretics, i.e. clothalidone and dapamide, may offer additional reduction. And here, the thiazides again, previous JNC guidelines have promoted hydrochlorothiazide. Actually, they were heavily promoted even by the NHLBI, and hydrochlorothiazide has no outcome data on the basis of clothalidone outcome data, which are substantial, like SHEP, ALLHAD, and SPRINT. We made the point in the American Journal of Medicine, there's no evidence that hydrochlorothiazide in its usual dose of 12.5 to 25 milligrams reduces myocardial infarction, stroke, or death. So the design of the study made it difficult to exclude the possibility, this is a quote from the guidelines, that longer-acting diuretics such as clothalidone is preferable to the use of a shorter-acting agent such as hydrochlorothiazide. Question, does this mean that clothalidone, once again, remains preferable to hydrochlorothiazide? Well, you can answer this question yourself. Okay. And this is probably a rhetorical question. Strong RCT evidence supports 4 classes of first-line agents, thiazides, CCBs, ACIs, and DARPs, due to their favorable profile for blood pressure lowering, cardiovascular prevention, tolerability. All other antihypertensive agents are considered secondary. Again, a direct quote from the guidelines. And my rhetorical question is, and this builds up to it, lisinopril, obviously, as you can see here, is the most commonly used worldwide. In the US, 91 million prescriptions in the year 2019, and 19 million patients are on lisinopril alone. Yet, when you look at the outcome evidence, very well documented, there is no difference between ARBs and ACE inhibitors. This is true in head-to-head trials. It's true in whatever study you look at it. Here, a multinational study by Chen in more than 3 million patients, except, of course, for the side effects. This is New England Journal of Medicine, 75-year-old man treated with captopril for more than 3 years, went to the ER and had angioedema. It doesn't happen the first day, the first week. It may happen after years of antihypertensive therapy. And it's potentially fatal. We don't need to go into this. And my question is very simply, and that's the rhetorical question, why are we still prescribing angiotensin-converting enzyme inhibitors? Adverse effects have to be shown much more prevalent in ACE inhibitors than ARBs, cough up to 1/3 in the Asian population, potentially fatal angioedema, given equal efficacy but a higher risk of adverse events. Why are we still prescribing ACE inhibitor? Shouldn't this drug class be moved to the guideline category of alternative agents? Okay, and finally, a word on renal denervation. The authors have to be commended in these guidelines. They are exceedingly careful when discussing RDN. Similar to ESH and ESC guidelines, renal denervation is classified as a 2B indication, a weak recommendation. ESC and ESH position RDN as a fourth-line option in resistant hypertension or uncontrolled hypertension. That is, in contrast to AHA, ACC, it's a fifth-line option, despite 4 drugs, including an MRI inhibitor. Then you should resort or consider RDN. In other words, ESH, ESC before or instead an MRA, AHA, ACC after the addition of a mineralocorticoid antagonist. Obviously, a substantial difference between the two. Now, again, these are the guidelines. While some trials show a small but significant reduction in 24-hour ambulatory BP, systolic by 3 to 5 millimeters over the sham arm, others failed to reach the primary endpoint. And this is, when you look at, again, the data carefully, you have what is called the fan response. Some patients respond, others do not respond at all, or actually do have an increase in systolic blood pressure. And when you look at this, the difference between the sham and renal denervation is not very obvious. Of course, it's statistically significant, no question about that. So only 60 to 70% of patients undergoing RDN experience a meaningful reduction in ambulatory SBP of at least 5 millimeters of mercury. And most important, predictors of BP response to RDN have not been consistently documented. As Venkata has said, still in search of the magic bullet, and this is one quote. There's another quote I like even better than the one by Venkata, and that's the one here. Immediately after bilateral operation, there is usually a considerable fall in arterial pressure, but it lasts a varying time. In a few, the pressure quickly regains previous level. In a few, it remains low persistently. In most, it slowly rises to about its preoperative values. And the chief difficulty, now universally admitted, despite early enthusiasm that there is no certain way of distinguishing between those in whom the operation will succeed and those in whom it will fail, even by employing batteries of tests. Well, so said by Sir George Pickering in 1962 on surgical sympathectomy. And what was said at the time, just about at the time when I entered medical school in 1962, it's still true today. Thank you so much.
Thank you, Franz. From a peace-loving country like Switzerland, you have really gave a lecture like a French Revolution, with beta blocker going under the guillotine, the ACE inhibitor went down like the Bastille Fort, and what not. It was really, really a fantastic lecture, which all of us sat up to listen to what's next coming. So yeah, it is interesting. It's extremely interesting. Now I will ask our own Professor Venkat Ram, whose every word about hypertension we take as a gospel truth, because, sir, I believe that you talk to God directly about hypertension, you discuss with God about hypertension and give us what you have discussed. So, sir, all yours, and then we will discuss the whole issue together with our very, very eminent panelists.
Thank you very much, Soumitra. My responsibility was to actually summarize what all the three speakers would have said and interject my own comments on guidelines in general, and then on some aspects which are not that much evidence-based. As you can see on this slide, programs of this nature are very important for medical education. If you read this slide, we will never be able to cover what is being published more and more. So I would suggest to the audience who are logged in, it's a very wonderful opportunity that you have to hear from people who have contributed so much to our understanding of hypertension, and they really have come to your door where you really don't have to go to the library and look at things. So programs of this nature are very important. In terms of the blood pressure control and cardiovascular disease, in most countries, cardiovascular disease appears to be decreasing, but in India, the cardiovascular disease is actually increasing. So this is the paradox, ladies and gentlemen, that we have, is that we are not able to imitate the success of cardiovascular disease reduction elsewhere, but on the other hand, we are going in the opposite direction. There are multiple reasons for which, including blood pressure, lipids, lifestyle, obesity, etc. But we have to keep in mind that we are going in the wrong direction in terms of our cardiovascular disease prevalence. Dr. Welton has shown data relating to how the new guidelines have suggested, if feasible, I want to put that in quotation mark, if feasible, to achieve a blood pressure 120/80. That's what the guidelines said. They're not mandating, but they use this word, if feasible, and I'm going to comment on it later on. Therefore, ladies and gentlemen, we have come full 100 years on what should be the ideal blood pressure if you want to have a long half-life. From 1935, now 1928, 2025, almost 100 years, we have come a full circle. About 90 years ago, it was predicted that if you had a blood pressure 120/80 and you don't have any other medical conditions or complications, you're expected to have a pretty decent long life. At that time, it was suggested if your blood pressure went up a little bit, then your life expectancy is decreased. If it went up a little bit more, your life expectancy decreased more. And if you have much higher blood pressure, there is a substantial reduction in longevity. So, ladies and gentlemen, the new guidelines that have been released and somewhat developed are telling us a story that insurance companies had known nearly 100 years ago. Ideal blood pressure, if you can have it, should be in the proximity of 120/80. Now, the problem with redefining hypertension and lowering the levels of blood pressure to qualify as hypertension changes the statistics significantly. When you lower the threshold to make a diagnosis, then the people in whom the blood pressure is controlled actually goes down. When you lower the target, the number of people who have uncontrolled hypertension increases, and the number of people who have achieved the blood pressure goals will become lower and lower. This is something that you have to keep in mind. When you have aggressive targets of our blood pressure, then there are more and more people who are going to be in the category of uncontrolled hypertension. This is the classification that Dr. Welton has already shown. I'll come back to this later on. Now, these are some salient features which have already been covered by Dr. Welton, but it is worth emphasizing that they have used the PREVENT score, which is a little bit more reliable as he has suggested. And for those of you who always ask me the question about hypertensive urgencies, you'll be pleased that the new guidelines have removed the word urgency and replaced it with severe hypertension. And many of you always ask, what is the goal blood pressure in patients with acute stroke? The new guidelines suggest that if somebody has intracerebral hemorrhage and has severe hypertension, you should try to lower the blood pressure towards 130 during 6 hours. This is an area that has been contested before, but the new guidelines suggest that it is okay to lower the blood pressure towards 130 during first 6 hours. Dr. Welton has already commented about pregnancy. I want to comment about resistant hypertension because in clinical practice, not many physicians actually follow the definition of resistant hypertension. As somebody who comes to you frequently, somebody who is not cooperative, somebody who is hostile, we always call them as resistant hypertension. But very rarely do we call resistant hypertension by the criteria that have been established. Let me tell you an example. At the meeting of the European Society of Cardiology a couple of weeks ago, there was a session on aldosterone synthase inhibitors and their usefulness in resistant hypertension. And I asked one of the presenters to look back and see how many patients were on a diuretic in the study, which was supposed to be resistant hypertension, less than 50%. So they called it resistant hypertension, but did not qualify for the definition of resistant hypertension. The new guidelines have used the word thiazide type diuretic, which has already been mentioned. The previous previous guidelines used thiazides, but this time they have used the phrase thiazide type diuretic, and I will get back to this very, very shortly. Now, cognitive function, Dr. Welton has clearly demonstrated one of the greatest benefits of lowering the blood pressure, lower than what it is. You may not achieve 120 by 80, but lower than what it is, appears to stabilize cognitive function. Actually, few studies have shown that the cognitive function actually improves with blood pressure control. And like all other guidelines, they emphasize accurate blood pressure measurement. That goes without any saying. But the categories of hypertension in the new guidelines are just two, stage 1 and stage 2. Dr. Welton has shown this already, and many of you were wondering until today, how are they recommending, if feasible, 120, if feasible, 120, and let me show you the data. These are the data that are already covered by Dr. Welton, but I am showing it in a graphic form. You will notice here in the CR-HCP project that in terms of the primary, secondary outcomes and mortality, they were all lower when the blood pressure target was 120 compared to 140. And similarly, in the ESPERIT study that Dr. Welton has shown, and this is what I'm showing graphically, comparing 120 to 140, outcome, stroke, mortality, they were all significantly lower at blood pressure 120 compared to 140. So, ladies and gentlemen, the new recommendation of blood pressure, if feasible, to 120 appears to be on the basis of very important 3 to 4 population studies, 2 of which I have shared large number of patients. In terms of drug treatment, they used the word thiazide type diuretic, and the hierarchy of diuretics is shown on this slide. I saw there are some questions on the chat box. We'll address them. I wouldn't say a controversy, but the debate, which is better between hydrochlorothiazide and chlorthalidone, I think the recent trials, which I'm going to show, appears to have resolved this controversy. This is an old study that myself and my late partner, Dr. Kaplan, did to look at the fall in blood pressure in patients taking thiazides or chlorthalidone. And we showed at that time that chlorthalidone was superior to hydrochlorothiazide, but this was not an outcome trial. It just showed it. But now there are outcome trials, one outcome trial with major analysis, and second one is sub-analysis comparing prospectively chlorthalidone and hydrochlorothiazide. I know there was a question about indapamide in the chat box. I'll come to it. But this was a study only comparing head-to-head chlorthalidone, hydrochlorothiazide, only study to do it. I don't think there'll be any more studies on this. when they looked at the blood pressure response between chlorothalidone and hydrochlorothiazide, they were very similar. And when they looked at the potassium level, which is very, very important, they were very similar. So the finding was both chlorothalidone and hydrochlorothiazide were effective in the treatment of hypertension, and the potassium homeostasis was very similar. But when they looked at patients with pre-existing cardiovascular disease, patients who were on chlorothalidone had fewer negative outcomes compared to hydrochlorothiazide in the same study, but pre-existing cardiovascular disease. And when they looked at primary outcomes, when they looked at the heart failure, again, in this subgroup, chlorothalidone was better than hydrochlorothiazide at the same level of blood pressure. Suddenly, on May 7th of 2025 this year, FDA approved low-dose chlorothalidone for the treatment of hypertension. My late partner, Dr. Kaplan, will be turning in his grave because he was a great proponent of low-dose chlorothalidone. In fact, he has written hundreds of letters to the company which was making chlorothalidone that they really have to produce low dose and not high dose chlorothalidone. But finally, FDA recently has approved the low dose chlorothalidone for use in US, hoping that it will have a broader application compared to previous higher doses. So at least between hydrochlorothiazide and chlorothalidone, the debate appears to be over. Both of them are effective in the treatment of hypertension, and low dose chlorothalidone appears to be quite effective and without major disturbances in electrolytes, and the outcomes were quite superior in head-to-head comparison in patients with pre-existing cardiovascular disease. Now, Dr. Messerli commented on beta blockers. He always has done that. The question would be, is it a beta blocker controversy or is it an atenolol controversy? All the analysis of beta blockers having negative outcome or lack of positive outcomes were all in patients who were on atenolol, but not on other beta blockers. So the controversy may be related more to atenolol due to its lack of lipid solubility, shorter half-life, whatever you have. But I don't think one should apply those findings to other types of beta blockers, although outcome studies are not as robust. And this is what Dr. Messerli has pointed out, that when you looked at the atenolol, then it appears to have either no favorable effect or actually sometimes negative effect. So it's a mostly atenolol controversy related dosage or its pharmacokinetics. When you look at other beta blockers, for example, metoprolol, primary prevention, secondary prevention, tertiary prevention, heart failure, about 3 to 5, 10 years study show that they are quite beneficial. Now, in heart failure, the newer generation of beta blockers clearly have been advocated by guideline committees and the expert committees. And the newer beta blockers, I won't go into too much, they appear to be vasoselective and they may have a vasodilatory effect. And unlike atenolol, they appear to decrease central aortic blood pressure. No major outcome trials, but few outcome trials do suggest beta blockers might be useful in selected populations. Dr. Grassi has actually one paper is going to come out very soon, and in which he is going to conclude that the best outcome in patients with hypertension is those whose blood pressure is controlled and in whom heart rate has been lowered. So this is used to be in the old terminology double product. Lower blood pressure, lower heart rate appears to be best prognosis in the long run. Now, some issues that I want to mention, not a criticism, but a critique. In fact, I have been asked to write a commentary on these new guidelines. I don't know if I will or not, but in preparation for it, if I do, then I have a little bit of a critique, not criticism. When a committee says blood pressure less than 120 if feasible, and that phrase if feasible is a very important phrase because primary care physicians might use that phrase not to achieve a blood pressure less than 120 because this is opening that you can say that it is not feasible, therefore we are not going to lower it. So I'm just wondering if that phrase could be disadvantageous, just saying that I will give it a try rather than I'm saying. RDN recommendations, as all other recommendations, are very vague. And one thing that Paul and others, I disagree, that they recommended workup for primary aldosteronism in patients with resistant hypertension, irrespective of potassium. As it is, people don't measure potassium on a regular basis. And now you're asking patients with resistant hypertension to get plasma aldosterone to renin ratio, irrespective of the potassium. And that is going to be a detriment in primary care because aldosterone renin getting in patients with normal potassium is going to be an extra test. I do believe that normokalemic hyperaldosteronism is rare. The usual hyperaldosteronism is always hypokalemic. If they don't become hypokalemic today, they become hypokalemic in the future. So I have some reservations that every patient with resistant hypertension should be worked up for primary aldosteronism, irrespective of the potassium. I have some difficulties with that. No specific blood pressure goals for the elderly in the new one. And most importantly, no guidance when RAS blockade should be suspended in patients with CKD, at what level of creatinine, at what level of potassium is unclear because this is a question that always comes up in discussions with clinicians. Now, I already mentioned about acute stroke. I have one difficulty with recommendations for home blood pressure readings. Obviously, there's a lot of interest on home blood pressure measurements because they may reflect the real blood pressure, but there's no standardization of how to interpret home blood pressure readings. This is what the new guidelines have suggested. 2 readings, few minutes apart, twice daily. I don't know what after releasing bladder is. I know what they're meaning, but this is actually from the guidelines that after releasing the bladder, 2 readings twice daily and 2 readings at night time. Do you really feel that you see a patient with hypertension, you're going to ask the patient to do all these things? The other thing is home blood pressure readings 3 to 7 days before the clinic visit. Is it really possible for you to schedule the patients only after they have taken blood pressure 3 to 7 days? It's not logical at all. We should have a better way of home blood pressure measurement and its interpretation. Otherwise, home blood pressure measurements will not get the respect that they deserve. And lastly, this is also they mentioned that for primary aldosteronism workup, one should give IV saline for 4 hours and check plasma aldosterone. Do you really feel that in a patient with hypertension in your office, you want to give IV salt and measure the aldosterone after 4 hours? Will not going to happen. Aldosterone to renin ratio is fine, but this IV saline thing is very antiquated. I don't think anybody has used it in the last 25 to 30 years. And pheochromocytoma, they suggest 24-hour urine or plasma metanephrine. In fact, 24-hour urine metanephrine is rarely done these days because of the collection problem. I would favor only plasma metanephrine. So my comments are really not so much on the validity of the guidelines, but some aspects of the guidelines may not be applicable in primary care, because Dr. Welton has already mentioned that the ultimate beneficiary of the guidelines would be primary care physicians, who are the guardians of public health, who are the people who see hypertension, diabetes, and lipids. Having said that, the new guidelines are always a step forward to achieve blood pressure control. So, Soumitra, with those comments, I will, if you permit me, I will conclude my part of it, and then we can start the panel discussion.
Absolutely, sir. Sir, again, we believe every word you say. It is gospel truth to us. Whatever Professor Venkatram says is the final word. So it was very fantastic sum up. And now we have got the three messiahs from three continents, the America, Europe, and India. And you are half Indian, half American, Dr. Ram. So the floor is yours because you are the moderator. So I think you should take up the questions and involve the panelists. Sir, all yours.
I want the audience and, of course, my co-faculty to know that we have a fantastic group of panelists who are highly accomplished. I'm going to introduce them, but one actually a former president of Indian Society of Nephrology, one former president of Endocrine Society of India, one former president of Indian Society of Hypertension. So three leaders on one platform I have not seen. At least I have not seen. So it's very interesting. Let me introduce the panelists in their alphabetical order. Dr. Ganapati Batwal from Bangalore. He is a professor and head of the Department of Endocrinology at one of the best medical colleges in India, St. John's College. As I mentioned, he's the one who was the former president of Endocrine Society India, and then he held so many roles in RSSDI and Endocrine Society, and a lot of publications. A true academic scholar in endocrinology in general and diabetes in particular, and he's trained so many people and done a lot of clinical trials. So we welcome Dr. Bantwal in his current capacity as well as in past capacity as the president of Endocrine Society of India. Next would be Dr. Sanjeev Gulati, who is a very prominent nephrologist in the country. He is a former president of Indian Society of Nephrology. He trained at Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow and at McMaster University, which is known for global research on population sciences, cardiovascular disease, therapeutic trials, etc. He was a former president of Indian Society of Nephrology. I wonder, I may be corrected, I wonder if he's the only adult and pediatric nephrologist qualified in India. Same, both very interesting, a big expert on transplantation. And of course, every transplantation physician, the goal is to prevent transplantation, not to encourage transplantation, but to prevent transplantation. That is the goal of heart transplant, kidney, liver. You have to prevent it by public. And he has trained so many fellows and MDs and DMDs and a lot of publications. And it's good that he has accepted to participate. Another is a colleague of ours for a long time and colleague of Dr. Welton and also Dr. Messerli. Dr. Narsingan, former president of Indian Society of Hypertension and the current vice president of World Hypertension League, and he was the chairman of the World Hypertension Congress in Chennai in earlier this year. First global conference held, and he's also the vice president and probably president, I guess, president-elect of Lipid Association of India. He has won so many awards for academic excellence, articulation of his speeches, etc. And he's the vice president of World Hypertension League. And in that capacity, he has worked with our faculty very, very closely. So, ladies and gentlemen, we have a faculty panelists who have distinguished themselves in this specialty and accepted to participate. So what I would like to do now is I will reverse the order. I will ask each panelist to give brief comments on the presentation, just brief comments because we have a lot of questions. Let me ask Dr. Narsingan to give his comments on the presentation so far. Briefly, Narsingan.
Thank you very much, sir. I'm really happy that for your praising words that you showered on me. Thank you. In fact, Dr. Paul Welton was highlighting about the importance of primary aldosteronism in those people with resistant hypertension. But if you recollect the 2024 guidelines of European Society of Cardiology, those people have advised that every patient who is diagnosed with hypertension need to be submitted for a screening for primary aldosteronism. I'd like to have a comment from not only from Dr. Paul Welton as well as from you, because you have stressed the importance. It is not possible for us to proceed with the investigation, even resistant hypertension. That's what you meant because of the inaccuracy and then IV saline infusion in those patients with hypertension. It is highly impossible. So that is one area where we have to have some sort of concrete ideas from the stalwarts in the field of hypertension. That's number one. Number two is about the role of SGLT2 inhibitors and the GLP-1 receptor agonists, which have now shown, though the reduction of blood pressure is about 5 millimeters, not more than 5 millimeters systolic blood pressure reduction in these two agents. And if they are also introduced in the treatment of hypertension, probably we will be in a position to restrict the number of patients who are jumping into resistant hypertension. That is my personal comment on that. And people have, I think Dr. Paul Wilton started showing about ESPRIT trial. ESPRIT trial is a Chinese trial which had reduced the blood pressure aggressively and less than 120. In fact, at the end of the study, if you look at the data, it is only 119 millimeters of systolic blood pressure was the one that was reached and not beyond that. I think there's again another area which requires further evaluation as far as the ESPRIT trial is concerned. And I'm happy that Dr. Paul Wilton highlighted the importance of controlling the blood pressure. Thereby, aggressive control even in the middle-aged people will reduce the chances of dementia. And final message what he had given is that if you are able to reduce the blood pressure by about 20 millimeters of systolic blood pressure, it is going to have phenomenal, amazing results at the end of for cardiovascular outcome. That is about Paul Welton. Dr. Messerli, in fact, I had an opportunity to be with him for 2-3 occasions when Dr. Venkatesaram also called me to be there with him. And I really like the way in which he has been dissecting out the information what was given as far as the beta blockers are concerned. No doubt the atenolol went very bad in all sorts of aspects of control of blood pressure, though the brachial blood pressure was coming down, the central aortic blood pressure was not coming down. And there was an increase in the amount of stroke and other things compared to the comparator drug. That's number one. And then the ACE inhibitors comparing to ARB, I think the data for ACI is much more when compared to ARB now. All the trials which were conducted on ACI were before 2000 years. Before, that is 2000, not 2001 and before that. After that, we don't have any data with respect to the ACE inhibitors. We have only the old data. As you rightly pointed out, the side effects are much more, so one has to prepare only for the ARBs. If you recollect the data about the reduction of albuminuria, the ARBs are much more powerful when compared to ACI. In fact, the irbesartan was found to have more amount of albuminuria reduction. That's again another important point. If you look at the data for ACI, much used in those people with the type 1 diabetes when compared to type 2 diabetes. You have more data for ARB in type 2 diabetic patients. So comparatively, all these drugs have been studied mostly in type 1 diabetes, ACI, in type 2 diabetes, it is ARB. I think it is time for us to revise our information with respect to our approach in the management of hypertension and albuminuria, CKD, diabetes. I think we need to probably go for the so-called ARBs rather than the good old drugs like ACI. That's about my comment on that. And I have my own questions, only two questions, if you permit me, Dr. Thomas.
Questions later on?
Is it okay?
Because, I need panelists, other two panelists to
Yeah,
comment.
yes, sir. Yes, sir. Yes, sir.
Can I ask Dr. Gulati to give his comments on the structured presentation so far?
Yeah. Thank you, sir, and good evening, everyone. These presentations have been really an eye-opener, and in many aspects, they do represent, a way forward. As far as I would just restrict my comments to the kidney aspect, the targets for, CKD, in fact, remain unchanged at 130 by 80. So, not really 120 by 80 for cardiovascular mortality, like cardiovascular mortality. I would also like to take up the comment that you made about when to stop ACE inhibitors. And yes, we were also looking forward. Now, we don't have any creatinine values because nephrologists are never scared about the creatinine, but yes, hyperkalemia remains, I think, the major indication for putting these ACE inhibitors or ARBs on hold, because the Stop ACE trial showed that even when you continue them, even in advanced CKD, the cardiovascular protection remains. And even once they are on dialysis, still the DOPS trial showed that the lowest mortality was with beta blockers as ACE inhibitors. So they remain one of the favorite drugs, ACE inhibitors and ARBs. Post-transplant hypertension, now there is insufficient data. This blood pressure control again remains one of the most important aspects to prolong the life of the kidneys even after kidney transplant. There are no head-to-head trials looking at mortality, morbidity, but when we look at the drug toxicities, the renal literature does seem to suggest that the calcium channel blockers do protect the kidney from the calcineurin inhibitors, which is one of the pillars of antihypertensive, which is one of the pillars of immunosuppression. And my last comment is regarding renal denervation. It seems to be coming back, in some of the articles, which was beautifully highlighted by Professor France, that there is still a lot of gray areas there. And one of the most important aspects is also that the most of the studies that looked at renal denervation, the inclusion patients had an eGFR of more than 40. So we need to be very, very careful once we are taking up. I have seen some referrals to me, that patients asking that can they go in for the newer therapy. I think this is where some of the cardiologists in our hospital are also very, eager to take these patients. And I have had opportunity to point this out, that renal denervation therapy, still there is a lot more unknown than known there. Thank you. I think I will pass over the podium back to you, sir.
Okay, Dr. Ganapati Paul, please comment on the previous presentations, please, from your perspective.
Yes, sir. Thank you, sir. Good evening all. So I'll be speaking on the primary hyperaldo part. So what has been said is, in resistant hypertension, 30% of the people actually are found to have Conn syndrome, and that is a reason a lot of emphasis actually has been placed. Only 29% I have hypokalemia. So in fact, if you add a diuretic, many of the so-called normal can become hypokalemic, and you could actually pick it up. We have to do a PSC PRA, and sometimes what happens, the ratios, if you have a clear-cut hypokalemia and you have an aldosterone more than 30, then you do not do a confirmatory test. But when you have values less than that, yes, you require to do. It's not that cumbersome. We do it for confirmation. And in one of the studies, they found a seated 4-hour value is actually better than a supine ones also. So that's another thing. And why we want to do this actually is, you are giving a specific treatment. So the sensitivity of a CT is just 53%. And age more than 35, they say you must go for an AVS. You will have to do a sampling, adrenal venous sampling. But the patient, if they refuses, we can just put him on a spironolactone. And that is a specific treatment. It's not important you just control, but you have to give a MR blockade. And this is a very cheap alternative. And that is the reason a lot of emphasis. And our endocrine society guidelines also tells the same. At least once in a lifetime of them, please check for that so that you can put him on the right treatment. So this is one comment. Yeah, pheochromocytoma, I do agree with you. Plasma-free metanephrines, without any doubt, is better because it's more simpler. Only thing is he should be supine here for at least 30 minutes before you take the sample. 24 hours is more cumbersome, all these things. So that's another one. And finally, the last comment is on thiazide versus CTD. Yes, we have moved to chlorthalidone. It's more 24 hours action, including when we use it for non-hypertensive events, we actually prefer a chlorthalidone because the hydrochlorothiazide has to be given twice daily, whereas this has to be given just once a daily, including its effects on reducing the urinary calcium excretion. Thank you, sir.
Thank you. My quick response, Ganapati, is I've seen a lot of patients, primary although, even if somebody is normokalemic, they will become hypokalemic sometime. Salt, when they, as you said, when you give them a little bit of diuretic, their potassium is so low. So what I'm saying is, unexplained hypokalemia is a good reason to do the workup. But somebody has persistently 4.5, 4.6 resistant hypertension, I would think it's unusual to find primary aldo, but I think it's we have moved significantly towards the identification of primary aldo. So that's one thing. And I just saw, because of you're talking about GLP inhibitors and SGLT, I think Narsingan did.
Yes.
Monjaro 2024 sales, in 2024 US sales, $12 billion, which is 96,000 crores in 2024. And in 25, they have already exceeded it all the way in September. So it's a kind of a drug to be to watch. I don't know what. Now, let us do one thing very quickly in the interest of the time. Nursing, and I'll come back to you with your questions, but let us look at the chat box very quickly. And then I'll ask, anybody can comment. Paul Welton, is he still there? Paul?
Paul is not there, sir.
So he's there,
Yes, I am.
Oh, yeah.
Yes, I am.
Oh, okay.
Yes, yes, I am here. Yeah.
Sorry.
I just make one quick comment. Fantastic comments from everyone. I really enjoyed it, and that's why you're experts. And we have clinicians, and it's important to have clinicians because they have to take all of these guidelines, which are no more than guidance, and actually implement them with an individual patient. And I would say keep it simple. The key here is getting blood pressure down. And, you know, when we look at it observationally, the risk goes up incrementally, and the higher the blood pressure, the higher the risk. When we're treating it, it's the exact opposite. The relative reductions in risk remain pretty constant, but the absolute benefit to the patient is greatest when you're going from a very high risk to, let's say, less than 140. There is incremental benefit to going to less than 130, but it's not as dramatic. And then as you get to less than 120, there's clearly additional benefit, but in absolute terms, it's not so great. So my point is, any reduction in blood pressure is good. The lower you can get it without the patient having symptoms or complications, the better it is for that patient. That's, I think, the bottom line.
Yes.
It's treatment really seems to be the inverse of observation. I don't understand the guidelines that have a different classification for saying what's high, or give it a term, hypertension, and what's the goal, because it seems to me they're pretty much interchangeable. It's hard to have a goal of less than 120 or less than 130 and say, well, we're not going to diagnose high blood pressure or hypertension till it's more than 140. I don't understand that.
Okay. The question for you, Paul, quick response from Dr. Grewal. why don't we have a globally acceptable normal blood pressure? Globally acceptable.
I would say for me, the globally acceptable pressure is the lowest you can have it, as long as it's physiological. Obviously, you can get low blood pressure because of morbidity. Heart failure will give you low pressure. It's not good. But if you are not getting it for a comorbidity, the lower you can have it, the better it is. We know this from isolated populations, and I've studied some of them, and there are about 30 of them, and we know that where they don't have access to sodium, they usually have access to alcohol, but where they don't have access to sodium and they have high physical activity, their pressures tend to stay low throughout life. So there's no reason for pressures to go up. So that would be my definition of globally acceptable optimal.
I think
And certainly less than 120 is very, very good.
I think, Dr. Ram, the question's biased was, why don't we have something like an United Nations? So all nations join together and come to a joint statement of a single blood pressure value, which should be acceptable by all nations. That is the idea, and that would have been fantastic. Idealistic world. And then we are not confused anymore.
Yes, I wish we could all be on the same page. And one of the challenges, as Franz has pointed out, with multiple guidelines is that people tend to focus on small differences rather than
Absolutely.
saying all of these guidelines are basically similar. They all say
Absolutely.
high is bad and low is good if you can achieve it safely.
I have just a comment for Dr. Hazra. I'll make a comment. The most comprehensive classification of hypertension is always the latest guidelines, whatever it is. That is most common. And now a question for Dr. Gulati, because there were no nephrologists among the main speakers. In patients with CKD and hypertension, use of an alpha blocker along with a centrally acting drug to control hypertension. I know nephrologists love alpha blockers, although they don't lower the blood pressure. But they also question is whether you could combine it with centrally acting. Sanjeev.
So thank you. Well, see, there is no doubt that ACE inhibitors or ARBs are the first line drugs, followed by diuretics, calcium channel blockers. And then, once you have used all 3 or 4 of these, then you are left with this entity where, you would be looking for options. And that's where, alpha blockers do come into the picture. And we are using them because some of the most difficult hypertensive patients have chronic kidney disease. But they come fairly low down, not up. And yes, you can use whichever combination you like. Clonidine is definitely a favorite. I think that is what probably Dr. Grewal whoever asked the question wanted to, because clonidine is easily available. It's cheap in our patients, and it's a very powerful drug, especially if you have hypertensive urgencies. It gives sublingual clonidine gives you a quick response if that's what was intended.
Okay. Dr. Ashutosh Sinha asking if the new guidelines are applicable to Indian population. This question should always come up with any guidelines. It's hard to give a conclusive answer. We have to leave it open until the Indian guidelines are released. One thing I already told you is that Indian guidelines are not synonymous with American guidelines because they still retain the old classification of hypertension. So if you do that, then obviously the American guidelines of 120/80 is not applicable. But you can always use that escape phrase of if feasible. So you can use that if feasible for your benefit, or if you don't agree with it. So it's like a ball. You can play it anywhere you want. Use that if feasible. Now the rationale. I don't think they elevated the role of clothalidone, but they used it as a thiazide type diuretic based upon those 2 major papers that I mentioned. Now, intracerebral hemorrhage, I commented on it. Paul, do you want to comment anything further on blood pressure goal, intracerebral hemorrhage, if you are still there?
No, not really.
Okay.
No, you did a very nice job in commenting on it.
And then the one thing about these meta-analysis of diuretics, and this any speaker can comment on it, any panelist can comment on it. Comparison with indapamide. There were 2-3 questions, and I'm combining them. Indapamide has always been available as low dose, and Europa and HiVet and Progress, they have used indapamide as a part of combination therapy. One thing about it is it was always available as a low dose. Pharmacologically, there is some debate whether this is a diuretic or a calcium blocking drug, because original development was as a calcium blocking drug, but it had a diuretic effect. So pharmacopoeia has described it as a diuretic. So unless we have hydrochlorothiazide, chlorthalidone, indapamide, head-to-head comparison, I don't think we can really say anything other than you use your preference, what you want to do. That is my comment. Anybody has anything else to say? Because there are 3 or 4 questions related to this.
Well, the one thing I would say for us in the US, most of our trials with the longer acting diuretic have been with chlorthalidone. When we think globally, unfortunately, many countries, they don't have chlorthalidone on the market. Indapamide is more commonly available across the world. And as you mentioned, it's been used in a couple of trials. Progress is very interesting to me because you really only saw benefit in the patients with Progress when they were on indapamide. The other agent, which I won't mention, didn't seem to do very much. So I think the evidence is stronger for chlorthalidone, but I think there is decent evidence for indapamide as well.
Paul, you have a very good point. Chlorthalidone was actually invented in Switzerland by Ciba-Geigy in the 1950s. It's no longer available in Switzerland. We have to, our patients have to go to Germany to have their prescriptions filled. So that's, a tragedy, basically.
One funny thing, Franz, I will say, and it'll probably ring with you. When I was starting in my career, the VA study came out, and the VA study, is, those of us who are older will know, used 2 agents, but 3 drugs. One was a combination, and then Ciba brought out a combination called Serapis. It was reserpine, hydralazine, and hydrochlorothiazide. And that was a triple therapy, single pill combination. And that was what I and most other physicians in the US used to treat blood pressure for many years. And then HDFP came out and they said, well, you've got to relearn how to do this. Start with monotherapy, take the full doses, then do the step care approach. So we're now going back to what Ciba used to supply us with, single pill, triple therapy combination. I call it going back to the future.
There is one question I will comment. Anybody else can comment, and we will conclude. Patient with hypertension 160 by 106 in 36th week of pregnancy, almost there, and cesarean section was done, which is the correct thing to do. And the patient has persistent hypertension requiring Azomax, which is amlodipine. I'll just comment on it. When you have hypertension that late, that is according to the classification, including the new guidelines, it is gestational hypertension. This is gestational hypertension, and anybody who has gestational hypertension or preeclampsia converted to eclampsia, even after the delivery of the baby, they remain at high risk. The long-term risk for 20-25 years is quite high. So it is not surprising the patient is requiring thing, because in some people, there is persistent hypertension after the delivery of the baby, and these are the people who have to be followed carefully. Long-term prognosis of patients who have recovered from hypertension in pregnancy is not as good as those individuals who never had high blood pressure in pregnancy. That is my comment on that one. Vasodilators, somehow, let us just call them hydralazine or minoxidil, which are used by nephrologists more than any other specialty. Even in resistant hypertension, I don't know why the documents don't comment on touching on hydralazine, increasing the dosage along with the beta blocker and a diuretic, or minoxidil. I'm not saying they're avoiding it, but somehow hydralazine and minoxidil don't get place in even in resistant hypertension. Sanjeev, you want to comment on it because you probably use more these than any other specialty.
Some minoxidil we are using, I mean, in resistant hypertension, difficult to control where, we have literally exhausted everything else, definitely. And I would agree that hydralazine would still being underused there. It still finds a place in the heart failure therapy, and where, isolazine is being used in combination as a combination therapy, I do find there. But minoxidil, definitely the last drug, we have had patients who have been on 7 antihypertensives, and the seventh one is always ended up minoxidil.
Okay, and then Dr. Malhotra, special populations, diabetes, CKD, and heart failure, the drugs, Dr. Welton showed one slide of compelling indications, so you might want to refer to it, or you might want to refer to the document. Nothing different than before. Now, intracerebral hemorrhage, we already talked about it. I think that's resolved now. That has been there for a long time. Now, the question comes, I'll ask maybe, let me ask the panelists about what do you all think of IV labetalol for hypertensive emergency. Ganapati, you want to comment on you shaking head? Narsingan, you want to comment on hypertensive emergency and IV labetalol? You can give any drug, but
Yes, sir.
we do not go into it. The question is about labetalol. You have anything to say?
No, sir. I'm not.
Sanjeev, you have anything to say?
So we have been using labetalol after, nitroglycerin, or as a, it's still because it blocks, it gives us a very good response in our difficult patients very quickly and easy to titrate also. No washout effect, I mean, unlike NTG. Yeah.
Okay.
Sir, may I give a comment here?
So I want you to comment very shortly because we're almost done with this, and then I'm giving the floor to you.
Sure.
Comment on it. No medical education program on hypertension in India is complete without a question on ARNI for hypertension. Anywhere you walk on the street, in the restaurant, in the elevators, in the restrooms, they're only asking me about ARNI. Even in the restroom, they're asking, I'm trying to fulfill my physiological duties. Soumitra, you take this up now. You take this.
Yes, sir. Sacubitril has certainly everybody has my experience is same as yours, and it was originally an antihypertensive drug. How it developed, it was an antihypertensive drug. I personally find it exceptionally useful in hypertensive population, though not yet recommended or by guideline directed, unless it is resistant hypertension or there is hypertension associated with heart failure with preserved ejection fraction. In these two situations, it is recommended, and I tell sometimes my colleagues that heart failure with preserved ejection fraction is rather you can always find it out if you want to find it out. In a hypertensive patient, long-standing with high blood pressure, an element of heart failure will be there in majority of cases. You have to find it out by symptom sign, by echocardiographic, and by NT-proBNP. And if you get it, there is a 2A indication for sacubitril valsartan. But why not changing the original RAS blockade by sacubitril valsartan along with calcium channel blocker and diuretic, which might change the definition of resistant hypertension. And if you use these three medicine rather than an ARB, many of your so-called resistant hypertension may not remain uncontrolled, and they may not need the fourth drug. So I've got strong opinion about it, but of course we need more proof and evidence to recommend it.
Okay, so there are a couple of clinical trials, one for sure. In the patients with elderly hypertension, it certainly lowers the blood pressure, no doubt about it. No outcome trials. We won't see outcome trials for a while, but maybe a heart failure and hypertension is a good drug. Now,
Sir, 1 minute, sir. Can I just interfere?
Yeah.
There is one meta-analysis published in Japan, and people have identified about 5,600 patients were recruited for these studies, and they have taken a meta-analysis and proved that this is a wonderful drug which can be used in the treatment of uncontrolled hypertension over and above the drug that had been used.
Yeah, it's approved in
Yes.
Korea.
In Japan. In Japan, it is approved.
Soumitra, what we can do is we're almost at the end. You wanted to say something, you can say it now. And
I just don't want to lose an opportunity of you three together. My long-standing one query about atenolol. You know, the UKPDS is one of the best designed trials. And even in diabetic patient, where RAS blockade should be the best drug, captopril is outperformed by atenolol. That is number one. And number two, we all know ASCOT trial, which actually made the tome of atenolol. But why not there was a resurrection after 14 years when the ASCOT BPLA long-term results published, where it was shown that only the stroke benefit remained, no other benefit remained, including the mortality, including heart failure, including MI. But we did not celebrate any Easter, Friday, Saturday, or Sunday on atenolol after 14 years of ASCOT trial. Any particular reason, sir?
France, Messerli?
Yeah, okay. Well, okay. Obviously the ASCOT trial is what it is, but there's also the LIFE trial. And in LIFE, it's directly against losartan. And losartan is one of the weaker ARBs. And even against losartan, atenolol loses substantially in terms of stroke reduction, particularly in isolated systolic hypertension. So there's no question in my mind, atenolol is a lousy drug for stroke prevention.
Yeah, I take that, sir. Yeah, that is always there. For stroke, atenolol is really, really bad, but may not be in other situation. So that's all from my side, Dr. Ram, and I think we are almost time.
I'm going to chat box one more time. I think we did everything. I just want to make final comments. This is probably the first program outside US to discuss the latest American guidelines, to the best of my knowledge. Surprisingly, Franz and I were there at European Society of Cardiology meeting 2 weeks back. Nobody talked about it, although it was published at that time. So it's good we have able to cover the salient features of the new guidelines, whether they're applicable to India or not. We have to wait for those things. And faculty, all the senior faculty, most grateful for sharing their knowledge. Wonderful panelists with their clinical expertise and practical utility to all the questions that were raised. We answered all the questions. There are some questions which have to remain unanswered. That is the nature of science, that it remain unanswered. So I want to thank IPCA for doing these academic partnerships to host the latest American guidelines for Asia. And I'll ask Sachin Nair to give vote of thanks. And after he says something, then it is certainly good night for most of us, good for a couple of people.
Thank you, sir. Respected chairpersons, esteemed moderators, non-speakers, distinguished panelists, and valued participants. On behalf of the entire IPCA team, it's my absolute privilege and pleasure to extend our heartfelt thanks to each and every one of you for making today's webinar a resounding success. Your presence, insights, and active participation in the Hypertension Update 2025 truly made this event insightful, impactful, and also very inspiring. We are deeply honored by the gracious presence of our chairperson, Dr. Soumitra sir. Thank you, sir, for leadership and guidance. A special note of gratitude to skilled moderator speaker, Dr. Padmashri Venkatesh Ram sir, for seamlessly steering today's discussion with such clarity, expertise, and even glimpse of the Indian hypertension guidelines. Our sincere thanks to all our eminent speakers who brought global perspectives and cutting-edge insights to the forum. Dr. Paul Wilton sir, Dr. Franz Messerli sir. Your contributions truly raise a bar. And sir, to our distinguished panelists, Dr. Sanju Gulati sir, Dr. S. N. Sir, Dr. Ganpati Bantwal sir. And for Dr. Anil Parikh sir for always being there with us and giving us insightful insights for this webinar. Your participation truly made the day enriching. Sir, we are proud to share that over 1,000 participants from across the country logged in today. And at IPCA, we are committed to empowering the medical fraternity in the battle against hypertension with a comprehensive portfolio of anti-hypertensive therapies, including the trusted clothalidone and our pioneering clothalidone combinations. We stand strong in the mission to deliver effective evidence-based solutions, sir. In closing, sir, thank you once again to all of you to make this event possible. Your time, expertise, and engagement are what today it made a meaningful and memorable experience. Thank you very much, sir.
And Paul Welton, the man who does not believe in jet lag.
Yes.
Jet lag free person, no jet lag at all. 2 hours back after a transatlantic flight and just looks as if he.
Oh, really? Oh. Very strong pineal gland. A lot of melatonin in the body.
Such a pleasure to be with so many great friends and colleagues.
Franz Messerli having a very too much comfortable life in Interlaken makes us all envious, but he deserves it after so many years of creating controversies which didn't exist or perpetuating controversies so that we can have continued discussion, Franz.
Thank you.
I think we'll, and of course, our chairman for the meeting, Dr. Soumitra Ray, for guiding the thing, and Dr. Anil Parikh for introducing the theme, because one of the few clinical pharmacologists that I know who knows the history of hypertension guidelines and drug development. So he's the right person to introduce the theme. So we will get some feedback later on, nothing on the screen.
Thank you. Thank you, sir.
And I think we can close the program and have a good evening or good afternoon.
Thank you. Bye-bye.
Great to see the Franz.
Bye.